Good morning. Good morning. Welcome to meeting number 5 of the Budget Review Subcommittee on Human Resources. As a reminder, remote access is allowed to all meetings for the 2021 interim session. Members were provided a Zoom link to access the meeting remotely. The meeting materials were put online earlier this week and made available for downloading. At this time, we'll have the secretary call the roll. Members, you will need to indicate whether you are present in person, remote from district, or remote from office.
Senator Rocky Adams.
I am on remote from the district.
Thank you. Senator Alvarado.
Present in the room.
Senator Berg.
Present in the room.
Senator Carroll.
Present remotely from my district.
Thank you, sir. Representative Bowling. Representative Frazier.
Present in the room.
Representative Gibbons-Prunty.
Present in the room.
Representative Sheldon.
Present from district.
Thank you, sir. Representative Weber.
Present in the room.
Representative Westrom. Representative Wilner.
Present remotely from my district.
Thank you. Senator McDaniel. Representative Petrie. Representative Reed. Representative Moser. Co-Chair Meredith.
Present in the room.
Chair Bentley.
Present in the room. Got enough? Okay. Next, we have approval of minutes from the September 24th meeting. Do I hear a motion?
So moved.
Hear a motion by Senator Meredith and a second by Senator Alvarado. All in favor? Aye. Any opposed? Okay, the minutes have been approved. Before we begin with the presentations, for members participating remotely, please remember to mute your microphones. This morning we're going to have presentations from a panel of speakers on the treatment of hepatitis C and services for individuals with substance abuse issues. We'll hear from Michelle Rose of Norton Healthcare, Danielle Revert with the Hepatitis C Treatment Center, and Dr. John Jones with the Primary Care Centers of Eastern Kentucky. Would you all please come forward and identify yourselves for the record? You'll probably have to pull those microphones closer to you, and yet turn one for all of us to hear. Members, hold your questions till after the presentation, please. I asked this group to come because in Eastern Kentucky, hepatitis C costs Medicaid a lot of money. And I want everybody to understand there is new treatment and the severity of the disease state. So, welcome.
Thanks so very much. My name is Michelle Rose. I work for Norton Healthcare, and it's an honor to be here today.
Thank you. I'm Danielle Revert. I'm a nurse practitioner with the Hepatitis C Treatment Centers. Thank you very much for letting us come speak with you.
And I'm Dr. John Jones. I'm the medical director at Primary Care Centers of Eastern Kentucky and Hazard, Kentucky, and we have been treating hepatitis C on a primary care level.
You're welcome to start.
Thank you so very much. And good morning again. My name is Michelle Rose, and I'm a population health manager with Norton Healthcare and a population health researcher. Let's see. So first, oops, we're not in the right slide. There we are. First, I'd like to acknowledge that Kentucky has made incredible strides in hepatitis C and continues to do so. And I think it's remiss to miss the opportunity of success. In 2018, Senator Julie Rocky Adams sponsored Senate Bill SB 250, Universal Hepatitis C Screening for Pregnant Women. Thank you. And then also incorporating that bill's documentation of infants that the diagnosis is in their permanent medical record, perinatal exposure to hepatitis C. This bill passed unanimously by the House and the Senate and came into effect in summer of 2018. really leading the way was that Kentucky was the first state in the nation to do this. And in 2 years later, the CDC updated its recommendations to match the recommendations that Kentucky had proposed in 2018. And in 2021, the American College of Obstetricians and Gynecologists followed suit. All right, are we on the right side? Yeah, we are. So, and then within the cabinet, sorry, one other thing on this one, within the cabinet, the Department of Medicaid Services under the State University Partnership Grant Program approved funding for identifying and removing barriers to hepatitis C treatment in Kentucky Medicaid populations. This was approved in 2019. And this study utilizes state Medicaid data, claims data, to really evaluate the scope of the epidemic as well as to evaluate the effectiveness of interventions. And then additionally, in 2020, Medicaid cleared the way for primary care providers to treat patients with uncomplicated courses of hepatitis C infection. And in 2021, the department launched the Hepatitis C Elimination Technical Advisory Committee. And that committee is its central role is to develop an elimination strategy for the state. So one of the things that I really enjoy about working in hepatitis C is that the virus is actually kind of tricky. And it first was sequenced in 1989, about 32 years ago, and whereby it finally, when that happened, it finally got its name, hepatitis C versus non-A, non-B, and it was confirmed to cause mild to severe liver infection. In the U.S. pre-1989, most HCV infections were acquired through medical procedures. But once sequenced, the U.S. initiated blood product, and solid organ transplant screening, so that transmission mechanism was essentially cut off. Even at that time, when that was cut off, treatment options were quite limited, but elimination was discussed, and that was how exciting this was. So in the early 90s, we marked the beginning of the rolling opioid injection use syndemic that we're still experiencing. And it's this syndemic that is driving the spread of hepatitis C. So today, the most common route of HCV transmission is injection drug use. And viral hepatitis comes in many forms, but the only way to know you actually have viral hepatitis or any of the hepatitis is through confirmatory laboratory testing. And lastly, there is no vaccine for hepatitis C, but there is a cure. So this slide is from our Kentucky Medicaid claims data. I'm one of the researchers on that project. And the increase in infection for the three main age groups that we'll focus on between 20 and 49 mirrors that of national trends. However, the rate of infection in Kentucky is about twice as high as the national average. And to contextualize this in terms of injection drug use, young injectors tend to have more social networks, as well as tend to share syringes and other items used to prepare drugs across these networks. And for the hepatitis C virus, the conditions for spread couldn't be better. The virus is incredibly durable outside of the body. Viability on a syringe or in a syringe is about 63 days. Viability in water containers and surfaces for up to 3 weeks, and viability on foils and filters 48 to 24 hours, respectively. So through the Medicaid claims data analysis, we know that routes of infection between men and women are equal over the lifetime, so about 50-50. However, young women are disproportionately impacted. 29%, as you can see in this slide, of all Kentucky Medicaid recipients with hepatitis C are women of childbearing years. And because of potentially fatal liver infection can be passed from mom to infant, this is very concerning. And we see this in the Medicaid data as well. Within the data set, there were 192 individuals under the age of 10 diagnosed with chronic hepatitis C. When we apply population study findings to this Medicaid data analysis, we can estimate that the actual disease burden is somewhere between 650 and 1,300 children infected with hepatitis C. And and the Kentucky Medicaid data findings are in support of other research. This is Quest data from 2011 to 2014. And you can see that overall, hepatitis C is increasing nationwide, but in Kentucky at a much higher rate. So women in nationwide had a 22% increase in infection during this time, but in Kentucky it was 213%. Children under the age of 2, there was a 14% increase. In Kentucky it was 151%. And in infants born to hepatitis C mums, it was 68% nationwide, but 124% here in Kentucky. So when we're looking at other comorbidities associated with hepatitis C in the Medicaid claims data, we did look for a dual diagnosis of hepatitis C and opioid use disorder. And the team did find between 40 and almost 50% dual diagnosis in patients between the ages of 10 and 39. But there is some good news on the horizon. When we did look at survival probability of those trends in HCV with direct acting antivirals, we found that those that were treated had very high survival rates versus those not treated. And you can really see survivability decreasing at about age 50. All right. And so the last bit of good news is what's been happening over time. There's been a number of changes to Medicaid and removal of barriers for getting treated. And so what you really see in the last data set that we have here in 2018, we still have about the same number of providers that treat for hepatitis C, but we have a considerable number of individuals being treated by that population. So thank you very much.
I'm Danielle again. So I'm a nurse practitioner at the Hepatitis C treatment centers in Kentucky. We're specialists, so we're liver specialists, and we've cured about 3,000 patients over the last few years. What I want to talk with you all about, I want to talk about access to care, and then I want to tell you about the disease process and why we go after patients to treat them early. Access to care wise. So access to care is always important in healthcare, period, but especially with the populations that are infected by hepatitis C. It's often a very transient population. I think we're still screen sharing. Okay. There we go. Sorry about that, guys. So it's a very transient population. It affects a lot of people that are transient for a whole variety of reasons. But because of that, you really have to grab people where they are, wherever they are interacting with the healthcare system. So what we have done in our clinics is we have decentralized our services, and we partner with local healthcare systems throughout the state to grab patients wherever they are. Now, sometimes that looks like us contracting with a huge healthcare system like TJ Sampson in Glasgow, and sometimes that looks like us partnering with a tiny inpatient rehab facility in Monticello, Kentucky. So it can kind of look like a lot of things. But the way we have done this is we have used telemedicine to totally expand our reach. Now, what you're looking at here is just an image of me dropping pins on a map for a couple of weeks of the general locations of the patients I was seeing. This is by no means it is by no means inclusive of all of the locations of our patients. This is just me dropping pins on a map when I remembered while seeing patients. Please keep in mind while you're looking at this map, I work for a small family business that employs less than 10 people, and we are not a huge academic facility with tons of resources. So please look at the reach you can have when you use telemedicine. Me personally, I would ask you, please protect telemedicine. Please protect telemedicine. It's the best thing that came out of COVID for sure. But what we do, and the other reason I put this map up here is because I want you to see that the patients are everywhere. The patients are everywhere. Every time I open a clinic in a rural site, I usually have people come up to me that are like, oh, we're so glad you're here, but we really don't have patients here with Hep C. And in Kentucky, it's just not true. So if you're not finding the Hep C patients in your clinics, I always tell folks you're not screening enough people. I think we all have this image of the person with substance use disorder, and we like to think that it's not someone that's in our community, but substance use is the great equalizer. And it is folks in your family, in your churches, at your jobs, and they are everywhere. They're everywhere. And telemedicine has just really allowed us it totally destroys a transportation barrier. It gives us access for specialty care in places that had no access to it before. And it allows us to interact with communities that are in inpatient rehab facilities where they're already interacting with the healthcare system, and we can treat them while they're there, wherever they are. Now, the reason we're so passionate, and I see a lot of really, really sick liver patients because I'm a specialist, okay? But the reason we're so passionate about going after people in this way is because hepatitis C is a progressive disease. So you start out with acute hepatitis C. That's when you first get exposed to the virus. The majority of patients will develop long-term or chronic hepatitis C. And once that happens, you can go on to develop cirrhosis. Now, when I say cirrhosis, everybody thinks about alcohol, but you can get it from hepatitis C as well. Once your patient is at that point, that is what kills people when it comes to this disease process, because it can lead to liver cancer. You're going to see HCC, that's hepatocellular carcinoma, that is liver cancer, and it leads to liver failure, which is when the liver stops doing its vital functions to keep you alive. The other issue you have here is that once you develop long-term hepatitis C, you can get what's called extrahepatic manifestations. Now, that is just a very fancy word of saying systems outside the liver system being affected by the disease. This is something we're learning more and more about. We used to only kind of connect hepatitis C to cirrhosis, but I could give you an hour-long lecture on extrahepatic manifestations, and we just don't have the time. But I hope you're looking at that list and going, man, this looks like every healthcare problem that ever exists. And I would agree with you. The liver has about 500 different jobs in your body. So biologically, it makes perfect sense that when it gets impacted by something, other things will fall apart. And I could tell you story after story after story of patients that I've treated that had improvements in other aspects of their health just by us treating them, whether it's diabetes, kidney disease, whatever. So early treatment's really important. It prevents the progression of liver disease. It's amazing. It's like you fix the problem before it ever really exists. You get not just, you saw the mortality data from Michelle Rose there, but it doesn't just increase their survivability, but also their quality of life. And patients are actually easier to cure if you treat them early. Treatment is 8 to 12 weeks. It's got a 98% cure rate. That is about as good as it gets in medicine, y'all. So they're wonderful drugs. They are very, very safe and very well tolerated. And it always breaks my heart when I see the very, very sick cirrhotic that knew they had Hep C for 15 years roll into my clinic, because I wonder if I had gotten to you sooner, would you even be in this situation? Financially, I put the financials up there for you all. They're showing you the annual per person cost in a non-cirrhotic versus cirrhotic patient, and then they're telling you the cost savings annual per person for a cured patient. So financially, it makes a ton of sense too. The very severe liver disease patients are very expensive, and it's a lot of burden on the healthcare system. And once you have cirrhosis, you get to hang out with a specialist for the rest of your life. So it's not just a short-term disease at that point. Treatment costs have dropped significantly as well, thanks to competition in the market, over 78%. And we really look at this, I tell people to look at it in an infectious disease perspective. When you look at the goals with hepatitis C with big organizations, the goal is elimination. That is how good the drugs are. The goal is elimination. How amazing that we live in that world. But you will never hit that if you do not go after everybody who has Hep C. And the people that are spreading Hep C in our communities right now are the IV drug use population. So we're kind of shooting ourselves in the foot if we don't go after them. So, thank you.
I'll try to pick up where they left off. So again, I'm Dr. John Jones. I'm the medical director at Primary Care Center of Eastern Kentucky. And so for me, I look at this from the primary care perspective. And so I say, what can primary care do? I think the single most important thing we can do is routine screening and testing. Again, if you don't identify the patient and know they have the disease, you'll never treat the disease. The thing I would tell you about hepatitis C is it's sneaky. So, people are asymptomatic. There's only one way you can know that some people have it, and that's through a blood test. So routine screening will be critical because early intervention is critical. So I would tell you that if you had to think about it in a certain way, think about it like cancer. Do you want your cancer diagnosed a month out or a year out? So clearly, the longer that it goes, the more complications you're going to have, kind of like they're talking about with cirrhosis and end-stage liver disease. It leads to liver cancer. So we need early intervention. And I'll tell you that the standard of care has changed just within the last few years. When I started, we screened people who injected drugs. we screened baby boomers, and that was kind of it. But now the recommendations are getting to the point where anybody that's over the age of 18, let's screen those people. And let me give you some examples of why universal screening, I think, would be good, because, we are talking about now that babies that are born with hepatitis C from hepatitis C infected mothers. So one example, a grandmother. She's on hemodialysis. She goes 3 times a week. She can pick up hepatitis C from her dialysis treatments, right? There's a machine. They unplug her and plug another one up. This grandmother can get it. This grandmother can be a baby boomer. She can pass it. She can have hepatitis C, not know it. Nobody ever screened her, and she passes it. You have the young mother who used IV drugs 5 years ago. She dropped it. She never did it again. She gives birth to a baby. Now her baby has hepatitis C. Can you imagine having a 9-year-old kid looking at a liver transplant at 10? There's no treatments, to my knowledge, that are approved yet for children under the age of 12, 13? 3. Yeah. So, there we go. So, that's one great reason. So, the other reason that I think primary care can be helpful is we can link patients to care. They emphasize this. When you have that patient in the office, you need to do as much as you can. Nobody's going to have as much contact with you as your primary care provider. A lot of times, we're the people that they trust. You can send them to a specialist. They've seen them one time. They're not going to listen to them. A lot of times they're going to listen to their primary care provider. So we can link them to care like medical-assisted treatment for their drug use, harm reduction programs, and the specialists. If they do indeed need the specialist, we can link them up with those people. So you have to do as much as you can with these people because they're in poverty, they have transportation issues. If you have to do as much as you can when they're there, and primary care can help with that. The other thing we can do is we can grade the liver disease. So, there's blood tests we can do. There's elastography, which is a liver ultrasound to gauge the fibrosis, how far along are they in their disease. And, we just spoke of telemedicine. How great is it that the primary care physician over here in Hazard, way out in the middle of nowhere, can do these tests, telemedicine with an expert, and boom, they have all the information that they need to get this patient started on treatment. And then the other part I would say is we can treat hepatitis C. So there's a fantastic program that I used. It's called CAMP. It's Kentucky Hepatitis Academic Mentorship Program. They trained us primary care providers how to treat hepatitis C. I have 4 providers in my clinic that can treat hepatitis C. We do all the diagnostics. We get everything together. And only if they're really complicated do we send them to a specialist. A lot of times they're grade 0, grade 1, and we can treat them right there in the office. Again, capturing that patient and doing as much as possible while they're there is key. So, what can legislatures do? So, making the hepatitis C screening a quality measure. So healthcare is continually moving towards quality of care, not quantity of care. Money talks, the rest walks. When you make it a quality measure, payments are tied to that. I think that's a great way to encourage providers to do the screening, because a lot of times, unless you tie money to it, it doesn't happen. The next thing I would say is allocate some of the opioid settlement funds for diagnosis and treatment. So, the devastation of the opioid industry has left a lot of problems in this state. The hepatitis C epidemic is a direct result of that epidemic. So I really think that this committee can see wisdom in using the funds to help clean up the mess that the opioid epidemic has caused and some of the side effects that we've seen from the problems with the opioid industry. Supporting primary care education programs like CAMP, I think that's a fantastic thing. I would describe this as, healthcare is a battle. If it's anything we've seen in the last 18 months, it was a battle before COVID. It's a battle now. When you put everything on a handful of specialists, it's like having 100 men fighting the battle with 1,000 in reserve. We need to mobilize as many people as we can, and I think that primary care can help get you extra soldiers to fight that battle. And then the next thing I would say, expand harm reduction programs through primary care offices. Harm reduction has been great where I live. We have the health department. You have needle exchange from 10 to 2 on Monday, Wednesday, and Friday. But our clinic is open 8 a.m. to 9 p.m. every day of the week. It's just natural that it would be much easier to get these people harm reduction and do needle exchange in a setting like that, because the needle exchanges are really limited, though they're appreciated. And I know that harm reduction can be a controversial topic. My day job was diabetes and treating diabetics, and so I watched people suffer who had a hard time getting needles and syringes, and I'll tell you, just politically incorrect, I was one of those people who said, my diabetics can't get needles and syringes. Why are we giving it to drug addicts? I don't understand it. But I educated myself. And what that led to was to follow it through to its logical conclusion, which is it only gets worse if you don't give them clean needles. If they share needles and spread hepatitis C, I'll take you back to the young woman who has a child. What did that child do wrong? So that's when I changed my opinion on harm reduction, and I think expanding upon it and making it easier to access, which I think primary care would be a good place to do it, is key. And then, any funding to identify hepatitis C patients and link them to care. So whether that's, more funds to Medicaid to support the universal screening as a screening measure, or whether that's helping with transportation, because transportation is one of the big obstacles, especially in rural areas, of getting people plugged into treatment, whether that's through a gas card with Medicaid or whether that's through using services that are already there, a taxi cab service or some other program that's already in use for transportation. That would definitely help plug people in to get them to diagnosis and treatment. And then last but not least, I would say, is removing the prior authorization from hepatitis C medications. If anybody in here is a doctor or a pharmacist, you know that you hate prior authorizations. You know you hate it. It's the bane to your existence. So, we know what we're doing. I think that anybody that treats hepatitis C knows it's nuanced. Each patient is different. There's certain medication for certain patients. I don't think we would prescribe the medication incorrectly. There is a place for PAs. But in this case, again, when you have those patients in front of you and you need to treat them, then you need to do as much as possible. And a delay with a PA, you may lose that patient. You may not see them again. You may not be able to get the medication to them. So I appreciate the time, and we thank you. And if you have any questions, feel free to ask. And if you have any interest in probably seeing any of our facilities and what we do day to day, we're there. We'd be happy to have you.
Thank you all for. Do you have a question? Okay. Thank you all for your presentation and keeping it brief. First of all, we have a question from Representative Frazier.
Thank you so much for being here today. I've found your presentation very enlightening and frightening at the same time. While you were speaking, I was also corresponding with our emergency medical director and our coroner, and I was asking about what processes they're utilizing. And the coroner does not test for hepatitis. It's only for the drugs of abuse, and our EMS is not drawing any type of lab work on their runs. And so I'm very concerned that our numbers may even be more than what you're telling us. And so I would just like to get your thoughts on that. And, that to me, that seems like an obvious place where we need to implement some screening, because these are the people that are truly on the front lines, not taken away from anything with primary care, because I'm supportive of that as well. But, these are often the first people that come in contact, especially in the opioid situation.
So for the 9 years of Medicaid data that we looked at, we actually found 66,733 infections. And of those infections, when we compare that to, so that's just the Medicaid population. And there was the last modeling study that was done. The modeling study estimated about 44,000. So there is considerably more infection than what we know. We have never found a good way to screen young men. So we see young women disproportionately impacted because we are screening them hopefully at pregnancy. We do not have good screening numbers on men. We don't have a good mechanism for screening young men. And it is also transmitted sexually. So it can be. So there's also some concern around that. So I think the underrepresentation of numbers is warranted. Yeah.
Yeah, these populations that are affected by Hep C are generally folks that are hard to capture with survey data. So she has all the numbers. I'm not a numbers lady. I just treat patients. But I will tell you that logically, our numbers are probably much higher than what we see.
And I'll just comment real quick. Our hospital, ARH and Hazard, they got a grant to check for hepatitis C through the emergency department so we would capture those people. And what do you know? It was there. And the primary care, not to disrespect myself, but they were not testing clearly, because the ER would find these people and then connect them to care.
real quick.
Yeah, I just want to say, so it would be your opinion that that would be a good use for the opioid settlement money is to give our EMS and coroner's offices to be able to capture that.
I think more screening. I hate to say I think the coroner's too late.
Yeah.
That's what we're trying to avoid. But yeah, definitely more screening just in general. Yes.
Thank you.
First of all, thank you for a wonderful presentation. I have actually two questions, and I should know the answer to this first one, but I really honestly don't. And I tell my residents, if you don't know the answer, ask. Can you get reinfected once you've been treated?
Yes, you can. Humans don't develop immunity to hepatitis C. That's why we don't have a vaccine for it. Well, one of the reasons. But you would be shocked at how few people get reinfected. It's kind of amazing because logically with substance use that people relapse. That is the reality of substance use. And do I treat people with reinfections? Yes, but way less than you would ever think.
Just to add to that, there's been quite a number of international studies on reinfection, and the reinfection rate is very, very low. And the studies were actually done in drug-using populations. And so the idea that you can't treat someone until they're sober or long-term sober is actually not true.
Okay, thank you. Thank you for that answer. And then my second question goes back to cost of efficacy. Clearly it looks like there's a need for screening in the broader population. Clearly the treatment is very efficacious. When this treatment first came out, I was at the VA at that point, and I think we were averaging $80,000 a patient. Where are we now? And even at the 80,000, I'm an imager. I'm not a body imager, thank God. But portal hypertension, cirrhosis, portal hypertension, hepatocellular carcinoma, I have lived and breathed this for years and years. Extremely expensive diseases. And what we're taught, as imagers, is everybody with hepatitis C eventually will develop hepatocellular carcinoma. It's just a matter if they live long enough to get it or if they die from the disease process first. Where are we as far as the cost of treatment at this point, and how are we covering that cost of treatment?
I don't know specific numbers, but we can I'm sure we can get them for you. They just published some new data showing how drastically the costs have decreased recently in the last few years. So like I said, the costs have dropped about 78%. It's hard for me to tell you the exact cost because it's not very transparent on my end. But I will say this, Kentucky did a really wonderful thing. They used to have fibrosis restrictions where they would not treat people until they had very serious liver disease. And it was a nightmare. It was a nightmare as a provider. So those have gone away, and that has made our lives significantly easier. And it's probably saved a heck of a lot of money because the patients that are young that we're curing, you never deal with the portal hypertension. You never deal with the cirrhosis. You stop it in its track. So, but I'm sure we can get you those numbers. Treatment is very well covered right now. And please let it continue to be. It's really hard to look at a patient too and be like, I can cure you super easily, but I can't get you the meds because they won't cover it. It's awful.
I did want to add to the comment about HCC. When we were looking at the Medicaid data, we also were looking for other disease states in progression to HCC. We're seeing about 1.2%, so that is what national studies have also found.
And
From the longitudinal data we have, we're finding that 1.2% of the patients that were diagnosed first with HCV went on to develop HCC.
And if I could comment just real quick, I would tell you as far as prior authorizations and Medicaid and everything restructured in July, I would tell you just on a primary care level, getting medications that are specialty has become very difficult now. Medications I prescribed before for hepatitis C and other disease states, it's always the prior authorization is they need to see a specialist. And then we're in COVID and everything else, and it's 4 months, 5 months. and we're in a rural area. It's hard to get them to Lexington or Louisville or wherever the specialist is at. So that has been a new roadblock that I have ran into in primary care.
And it's not just in primary care. I've had issues, and I am the specialist. They're like, "Are you a specialist?" I was like, "Yes, I'm a specialist. Please give me these meds." And I've had issues with patients who were very, very ill, and it delays the treatment, and you really just want to throw it at them before they decompensate and have issues. It's hard.
The three big barriers that were removed from Medicaid starting in 2018, the fibrosis requirement was eliminated, sobriety was eliminated, and then in 2020, the need for a specialist for what they call uncomplicated disease state, so no HIV, no hepatitis B, and not advanced liver scarring, can be treated by primary care providers.
We have 5 more questions. I'll go on to the next questioner. Thank you, Doctor, for your questions. Senator Alvarado.
Thank you, Mr. Chairman. Thank you all for presentations. I made a few notes here as we were talking, and I think one of those was just answered by just your explanation on treatment course. I know when I was in clinic, I remember probably 10, 15 years ago, there was commercials on TV saying, go get checked for hepatitis C. And then come into I saw a commercial on TV, doctor should get screened. I'm like, do you have any of these risk factors? No, we don't need to do that for you. That was my mentality at the time. We've come a long way, obviously, with that. And, there's a lot of people, even when we think of IV drug abuse, I think of people with homemade tattoos. I mean, simple things that, it's pretty common in Kentucky. You see a lot of folks have done those. They share a needle somewhere, they get something injected, they can contract it that way. 2 things, telehealth. This state's been pretty advanced. I think we had the telehealth stuff laid down before COVID hit, fortunately for us. I think you got a pretty committed group here in the General Assembly that's here right now, at least, to continue to try to be on the leading edge. I think we've been one of the more leading states on telemedicine. I wanted to go back to your slides from Norton's on the infection issues, and there's 2 things. One, I'm glad we have these committees that we have different chairmen, and we try very hard to cover different topics to make sure we hear about these things, because there's not enough time in health and welfare alone. So we're able to cover a lot of this information. So having this discussion a bit more in depth on hepatitis C here is great. One of them was the increase in women. I mean, I'm surprised to see. I've always considered this more of a, and I guess more maybe my own bias of thinking, well, it's, I've been a prison doctor before. I've seen a lot of young men in prison, and you think about guys we would check them all. They had a lot of Hep C there. Again, a lot of the tattoos, IV drug use. To see this many women, this is before we passed the bills to require screening during pregnancy. Maybe if you could comment on why women, obviously children, I'm sure is from that. The second little blip here, it's small, but catches my attention, is the very next slide on dual diagnosis of HCV and opioid use. The fact that, if you go to the next one, at the very, very left, 0 to 9-year-olds, that we actually have a significant percentage of some amount of having opioid use disorder and hepatitis C at that age range. Maybe if someone could comment on that as well, because that's stunning to see that their kids that young already with opioid use disorder in our state and hepatitis C would suggest that there may be IV drug abuse issues at that young of an age range. Maybe if you can comment on both of those topics. Thanks.
Although injection drug use is very masculine, women are recruited into injection drug use typically through their partners. Women typically learn how to inject through their partners, and early on, they pay for their drugs by giving their partner some portion of the jab, and either before or after. So you have that kind of needle sharing. They're exposed to a lot of violence, and economically, they are just incredibly vulnerable. And so we really see that across patient populations and in young women. In terms of the 0 to 9. We couldn't dial down into whether it was neonatal abstinence syndrome. My guess is in the very, very young ones that are co-infected, that have the dual diagnosis of HCV and opioid use disorder. These are infants that are born to Hep C positive moms with neonatal abstinence syndrome.
All right, that clarified. That was scared me. I thought, man, if it's that young and they're already using those things, do you think the numbers are better as far as screening because we're doing a better job of screening as providers? I mean, clearly that sounds like it's improved. And again, it's just from where we were early on, where it was that, well, if you're not fitting these categories, you're not a high enough risk. At least that's how I kind of approached things 20 years ago. Yeah. Now we're just screening everybody, and it's becoming a more modern thing to do.
So under SB 250, all women in Kentucky should be screened during each and every pregnancy. If they are not, there's no way, again, as we've said, that there's no way to know if the infant has acquired HCV through perinatal transmission. I think screening infants or up to 2 is a really complicated topic. Part of it is that oftentimes the children will be lost to care or lost to follow-up. And and if there's no disclosure that the mom had hepatitis C or that screening was missed, then we don't know to screen the infant. So I think screening rates in women are definitely improving. I don't think that we have the whole mechanism dialed in for screening children and what that should look like.
Thank you.
Representative Bowling.
Thank you, Mr. Chairman. Thank you all for the presentation. As a pharmacy provider, I hear you on the PAs. A lot of times we'll do a lot of work with the doctor's office, which is right next door to us, to get that paperwork through, only to find out that it has to go to specialty pharmacy, which is owned by the PBM that makes that decision. But anyway, that's another battle for another day. Thank you for the information. This is obviously very concerning. Here, Kentucky has twice, the rate of the national average. We've heard a lot about, I guess, from the public health or the medical perspective on what we should do, and you all listed several examples of things that would make the process easier. As the legislature, if y'all suggested one thing that we could do as a legislature to help on this issue, what would that be?
I think the Medicaid measures for screening are crucially important.
Thank you.
Mm-hmm.
Yeah, I'm not sure whether to pick the screening or the PA. I'm torn between both of those. Both of those would be really key areas.
I picked screening for the patients,
Okay.
the PA for myself.
Thank you.
Great. And I've got one more quick question. Representative Frazier kind of touched on this, the opioid settlement money. Are you all able to use that in addressing this issue? Is that something that can be done?
I think if you wanted to fund things like screening and things like that, I think that would be a fair way to help fund those things, because a lot of it's going to be Medicaid. And of course, I don't understand how it's all funded, but that may, because the screening would pick up. If you made it a quality measure and tied it to payment, we're going to order more tests. That's going to be more charges to Medicaid. I just, that's how that plays out in my mind.
Okay.
I would say, just to add on that, with the screening, it would also help us identify patients with hepatitis B as well, and also very expensive and awful infection.
And rising. I've never seen more co-infected patients in my career than right now. That's purely anecdotal in my personal opinion, but in the last year, I'm just shocked at how many.
Thank you all again. Thank you, Mr. Chairman.
Senator Meredith.
Thank you, Chair. And echo the sentiment. Great presentation. I appreciate you all being here today. And I have just a little bit of interest in rural health care. I'm certainly a proponent of using the opioid funds for this. I think it makes sense. I mean, there's obviously a relationship here. But you made the statement about additional Medicaid funding, and I found that kind of interesting that we're already spending $15 billion this next year on Medicaid funding. And I found out that in Kentucky, what's everybody's responsibility is nobody's responsibility. We have delegated a lot of this responsibility for managed care to our managed care organizations. And they told us last Thursday what a glowing job they have done on improving the health of the population in Kentucky. Obviously, if we're doing screening on the front end, it saves money on the back end. And I think we need more measures like that. So have you all ever had an experience with a managed care organization coming to you and say, we recognize this is a problem, here's what we propose to address it?
I have not.
Find that very bewildering, Chairman, given that they're responsible for the health of our population, but they're not addressing this critical issue. So my position is the money's already there within the Medicaid program. They should be addressing this, and that they had not been more proactive about it is very disturbing. I wouldn't use it as an impediment to try to get additional funding for you folks, but it goes back to accountability for our healthcare dollars. If we're spending the money wisely, then we get a return, and that makes funds available for everybody. But I appreciate your presentation and appreciate your response. Thank you.
I agree with you, Senator, before I get any further. Representative Weber.
Thank you, Mr. Chairman. Thank you all for a good presentation today. You've given us a lot of information to process and think about. In light of all that information, I'm going to boil this down to one question. What happens if Kentucky doesn't become more aggressive in identifying and treating hepatitis C?
People are going to die. I mean, you may not see it now, but 10, 20 years down the line, you're going to have a slew of cirrhotic patients that are going to have a whole myriad of poor health outcomes, and they're going to cost the system a lot of money. I mean, Senator Berg can tell you all about the long-term issues, but I always tell people that one complication of cirrhosis is going to vastly outcost you what it would have cost you to just treat them in the first place. So you're going to pay for it later, and it's not, you're going to pay for it in finances and lives and quality of life. Hep C, like with diabetes and renal disease and cardiovascular, it's a catalyst. And so it's not just the liver you're worried about. You're going to have poor outcomes in a variety of areas of health. And Kentucky has a lot of people with comorbid conditions. I'm sure you're all aware of that. So it's particularly problematic for our population.
Representative Prunty.
Thank you, Mr. Chairman. I don't have a question. I do just have a comment, kind of an overarching comment. As I have a sister-in-law who survived Hep C, so I'm grateful for treatments and that sort of thing. To me, it's a bigger issue of needing public assistance reform. I think if we had public assistance reform in her life, I feel like she might have been more productive and maybe not have turned to drugs. So I just put that out there since Medicaid's under the cabinet. So thank you, Mr. Chair.
Okay, and the last question, Senator Burke.
And you may not know the answer to this, but relative to these other costs, does anybody know what the cost of the actual serological evaluation, the blood test to see if somebody has hepatitis B and C costs?
It really depends on the payer and what's been negotiated with that payer. But the actual baseline cost is very limited. It's not
$40, $50.
When I last priced it, it was about $14 for an antibody test, and then that was rolled into a quantitative PCR, and that was another $50.
Wow. Okay. Talk about an ounce of prevention. I mean, seriously.
It's a fairly inexpensive test, and you want to keep that testing algorithm together where you're doing the antibody, and it's what's called a reflex, and it's reflex at the lab level, so that if a patient does have active virus or viremia, then the test will have a diagnostic test. We'll have a diagnosis.
Thank you.
And that's all the questions. I just want to make a comment. We've come a long way, baby, from the first hepatitis C treatment. And the research, it's amazing to me that they could find anything to stop, most of us in the room know, translation, and that new drug stops at translation. Am I correct? That's amazing to me as a pharmacist, that they can do the research and do that. So there is hope, and like you all say, we'll be working on PAs and quality. Thank you all for coming. And that would really reduce a lot of money. But I want to ask Senator Meredith if he has another question.
Not a question, just a brief comment, Mr. Chair. And again, a great presentation. And this is such a serious issue, and we need to move this up. But I just want to comment, Chairman, that the MCO is not having a plan to address this. It's an epic failure on their part. Since, again, they are vested responsibility of improving the health of our population, and there needs to be some accountability to this. They need to be on front of this and tell us how we can get this issue resolved. Thank you.
Okay, there's nothing on the remote, so thank you all again for your presentation. Next, we'll have a presentation on Casper system. We will hear from Adam Mather and Dr. Connie White with the Cabinet for Health and Family Services, and Dr. Russell Travis and the Neurological Consulting Services, and Van Ingram, Office of the Drug Control Policy. As you all come forward, would you please identify yourselves for the record? And again, members, hold your questions until after the presentation. And I think we have to be out here by 12:30. So are all those people on the remote?
Yes, Chairman.
Okay.
I mean-
So there's no one here live.
No, Chairman.
Gosh, I wanted to see Van Ingram. See what he looked like again. Okay.
Yeah,
Just older and a little heavier, Chairman.
Okay. So you're all welcome to start, whoever you want to start first.
All right. Thank you, Chairman Bentley and committee members. My name is Adam Mather. I'm the Inspector General for the Cabinet for Health and Family Services. And in my purview is the Casper program, which is the Kentucky All Scheduled Prescription Electronic Reporting. If I could get someone from the LRC team to put up the slide presentation, that'd be great.
Do they have one? Okay. We'll get that up. Keep talking.
Sure. Yes. So just a quick definition of Casper. Casper is Kentucky's prescription drug monitoring program. Casper tracks Schedule 2 through 5 controlled substance prescriptions dispensed within the state as reported by pharmacies and other dispensers, and provides a tool to help address the misuse, abuse, and diversion of controlled pharmaceutical substances. Just a little bit about the state fiscal year 2021 Casper operations. We have had over 10.5 million controlled substance prescriptions reported to the system, over 36.4 million. I see they're starting to share the screen, so I will make sure they get on the right. Here we go. So we're on slide 3. If you can zoom to that, please. Perfect. Thank you. So Casper data is updated within 1 to 2 days, and dispensers have 1 business day to report their information. And then reports are available to authorized individuals, and those are done via either the web within a couple seconds, and anybody with computer access has access to that. If I could get the next slide, please. So this is a visual of the top prescribed controlled substances by therapeutic category. And you'll see the top 2 are gabapentin, or the brand name is Neurontin, and then hydrocodone. Brand names are Lortab or Vicodin. It followed shortly by oxycodone and Percocet. Brand name Oxycontin and Percocet. And then if you'll switch to the next slide, please. So this gives you a visual of Casper features and then collaborations that we're doing to be proactive in our work to slow down and hopefully end the opioid crisis within the state of Kentucky. And so we'll go into those a little more in depth, but you can see there's some really quality work that's being done on behalf of the Casper team and collaborating partners. And I think Dr. White and Dr. Travis can speak a little bit more on that, as well as Van. If you'll turn to the next slide, we'll go in a little more in-depth overview of some of those enhancements that we've done. So the opioid overlaps. So this identifies overlapping opioid prescriptions, and this is for potential misuse or abuse from patients. And this, the next one is really critical, as we're bordered by 7 states, informed interstate data sharing. So this allows us to share prescribing information among states around us and throughout the entire country. And then we have direct messaging, and that is a secure message portal that will send Casper information to important entities if there is prescription pads stolen, doctor shopping, anything that would rise to the level of what would be suspect for any misuse or abuse of any Schedule 2 through 5 drugs. And then lastly on this list is the Find Help Now link, and that is shown on every patient report. That helps prescribers define and share with their patients where there's an opportunity to get help if it's needed. And you'll notice an asterisk next to the informed interstate data sharing and the direct messaging, and that was funded 100% through the Hal Rogers grant. And so we're very appreciative of that. And then if you'll turn to the next slide, please. So I won't go into each of these, but I think you can see that there is a huge amount of collaboration that is done not only within our agency, but throughout the state and nationally. And so you can see how some of the work that we are able to participate in has really helped to work with agencies as they're trying to slow down the opioid use within the state and the country. And I know we're on a time crunch, so I'm trying to move quickly, Chairman. And so if you'll turn to the next slide, we'll go through that. So currently we're in a modernization program. Casper was originally built in 2005 and has gone through numerous iterations through the process. The goals of the Casper Modernization, which is a CMS funded initiative, 90% CMS and 10% general funds, is really to improve it, to bring it up to date, to improve the screen's design and usability to what we're used to.
Can't hear you. What do you say, guys?
Frozen.
Somehow we lost him. Anybody else?
Sorry about that. I got cut off. I apologize. I don't know what happened there. And then, can you hear me, Chairman?
Yes, sir.
Okay, sorry about that. And then, overall improved performance from the program itself. And then, if I could get to the next slide, please. So we'll talk about funding. Funding streams include CMS, which I mentioned that they provided us $2 million, and that is for the modernization of Casper. And that is a 90-10 federal to state match. And so currently we are at the federal spend thus far as of 9/16 was $629,000, and the state spend was $69,000. And then the Hal Rogers grant funding for the past 3 federal fiscal years at approximately or roughly under $3 million. And so we've provided both updates to both the Hal Rogers grant and CMS, and they require, I know CMS requires a quarterly report, so we've been providing that as well. If I could get the next slide, we'll kind of go and thank you. Go into the progress. So in partnership with developers and business analytics project managers, we're successfully engaged in developing activities around new and innovative ways for people to look at the information and get accurate data so that they can prescribe appropriately and dispense appropriately. And then regular progress demonstrations are held with the software for, we have annual reminders, patient request reports and status of request. We do NDC maintenance and pharmacy maintenance. And then our planned implementation of the modernization is going to be in the summer of 2022. Next slide, please. So in the last budget bill, there was there was asked for an RFP for a similar product to look into. And so to see if there was a vendor that would provide a consistent product similar to Casper, what we currently have, meeting the state's requirements. And on March 11, 2021, CHF issued the RFP to solicit vendor proposals. And that did take a little bit longer just because it's a very intricate system. And so it took us a while to build out all the components that we would need to be required through those vendors. And that RFP closed on May 12, 2021. And the current process, it's still open and it's still moving through the process. So unfortunately, we're not really able to answer very many questions about that. And I'll turn it over to Dr. White, because I think she can talk to some of the proactive approaches that we've worked through. And after that, if Dr. Travis would share a little information, and then if you have questions, we'll open it up. I think Ban has always been a real asset and helpful to work with through the Casper program and can help answer some of those questions.
Please continue.
Thank you, Adam. Reading an article in one of my OBGYN journals, because that is my training as OBGYN, there was an article about how they were monitoring women that were discharged from the hospital after delivery and the amount of opioids they were sent home in with, and it seemed excessive to me. So I had a conversation with the Casper epidemiologist and said, gee, I wonder what we are doing in Kentucky. Within a couple of days, Dr. Baronis had given me a report on the number of opioids that were prescriptions that were filled by women who had had uncomplicated vaginal deliveries and cesarean sections, and it was very eye-opening looking at that trend. We were concerned about medicine left over in medicine cabinets, and as y'all are all aware, diversion, they could be stolen, they could be used in an overdose, and so we took that information and shared this not only with the OIG with Adam about our concern about some of our hospitals prescribing very high doses and what that effect might have on our women. So Adam and I have tagged along, have done some phone calls with some of the hospitals that are prescribing very high amounts of opioids, and if we don't have enough results yet to give you a report, we have just started doing that. But we've gotten great reception and some very good response from the hospitals to try to make sure that those providers are not sending these women home with large amounts of opioids. We've shared this information. Our Kentucky Perinatal Quality Collaborative here at the cabinet, we've shared that information with the SOS program that KHA has, the statewide opioid stewardship program, and they're interested in helping us spread this information. And we've also reached out to some other states about what we've done, and other states are interested in sharing this methodology because they want to look at this issue in their state. So this is turning into a national project that we were able to use the Casper epidemiologist to develop this for us with this in a matter of days. It's extremely helpful, and we plan to continue to monitor this over every year.
Keep that out.
Do you want me to talk about displaced opioid patients now, Adam?
Yeah, that'd be great if you don't mind.
Okay. Another project the Department of Public Health has, we were responding to several years ago, a large pain clinic in Louisville closed, and there was concern about what was going to happen with those displaced opioid patients. And we realized that when and someone said earlier today, I believe it was Senator Meredith, that if a problem is nobody's problem, then that makes it everybody's problem. We didn't have a statewide plan. What do we do with displaced opioid patients? So we pulled together a group, the boards of medicine, dentistry, nursing, EMS, pharmacy, the Kentucky Primary Care Association, Van's group and the Office of Drug Control Policy, the APRN and Certified Nurse Midwife Group, KMA, the Pharmacists Association, Hospital Association, DEA, the Poison Control Center, and a whole host of members belong to this group that are in the cabinet to try to figure out what do we do when there is a closure and what happens to those patients. And Van can take it from there.
Thank you, Dr. White. Chairman Bentley, Chairman Meredith, members of the committee, great to be with you today. We've had kind of a change in Kentucky in the last couple of years, and that is the DEA and other enforcement agencies have gotten to contacting us before they go in for an enforcement action, which we used to always chase our tails, and we would, after the fact, try to figure out what to do. But there's a small group of us that have been charged with that information, and they'll come to us a few days before an action is going to be taken on a provider or a pharmacist. And in the day of that action, they'll actually contact Adam with the name of that provider. So within hours, we can do a report and see how many patients this provider is taking care of. What are the MMEs of opioids that this provider is prescribing? If it's a buprenorphine doctor, we can determine that we're going to have this many 100 patients that are dependent on this medication who are going to be out of it very shortly. So it's really helped us to respond in a very proactive manner and get resources in place. The DEA, KSP, and other enforcement agencies have been really, really good to work with us and actually post signs at clinics, provide information through social media, through local media. If you're a patient and need help, call this number. Our Poison Control Center has stepped up and said, we'll field those calls of displaced patients, and the Kentucky Pain Doctors Association have stepped up and have said, we'll take care of these folks. The Board of Medical Licensure has worked with us on relaxing some language so these patients can be taken care of. Because even if a provider is doing some nefarious things, often they have very legitimate pain patients within their practice. Or if it's a buprenorphine, they have very legitimate people receiving medications for opioid use disorder within their practice. And we want to make sure those folks are not turned to the streets, seeking heroin, ending up with fentanyl, and then ending up a statistic.
Thanks, Van. And Dr. Travis, if you wouldn't mind sharing your experience, I think it's very helpful to get it from a provider out in the field. That would be great.
Thank you, Mr. Chairman. Thank you for this opportunity, and members. I'm going to speak first as my tenure. I was privileged to serve on the Board of Medical Licensure from 2007 to 2018. I'm going to first share how invaluable Casper is to the board's function. Then I'm going to make some comments as a private practitioner, what it means to me. I saw firsthand how Casper helped the board try to control prescribing problems during the opioid pandemic. Every time the board receives a complaint or grievance regarding controlled substances, one of the board's investigators is notified, and that investigator immediately contacts Casper for one of the many investigators that they have, the pharmacist. And that OIG person then checks the records of the prescribing physician of whom they're concerned and pulls some reports that we can use as a board to have an expert of similar expertise review those charts. And then frequently that pharmaceutical representative will actually join the investigator in the field. And sometimes they'll even testify during the physician facing a disciplinary action. Just a snapshot of how Casper worked. I was on the board from 2012, and I was on the board from 2007. I was on the board in 2012 when your House bill had tremendous House Bill 5 was enacted, House Bill 1. I checked on during the board that time after House Bill 1, the board got 377 investigations involving prescribing controlled substances. And every time the board gets a complaint, we are obligated, they are obligated to investigate that. And it's done in conjunction with a representative of the Casper OIG. So we had 377 cases, of which 314 had disciplinary action as a result. Disciplinary action usually involves physician education. It may take some disciplinary action, but it usually involves some education of that prescriber as to how to do it appropriately. No question that if it wasn't for Casper and their representatives, the pharmaceutical investigators, the board would have never been able to face the opioid crisis as it did. They were able to really control or ride during the opioid crisis, but it would have been not possible without the Casper and the pharmaceutical investigators. As a private physician, I can tell you what it means to me. During my tenure as chairman of the board, I put on 3 opioid conferences throughout Kentucky, one in Lexington, Louisville, and one in Northern Kentucky. We were able to get tremendous pharmaceutical investigators to come and talk, as well as Van Ingram, to give a lot of information to private physicians about how to prescribe opioids, what to do with the opioids. Their expertise was invaluable. But as a physician, as a consultant, somehow, I guess because of my tenure on the board, I've inadvertently and been drugged, kicking and screaming into being somewhat of an opioid investigator or expert. So I frequently get charts to review somebody's been on opioids for years. I can get 10 years of opioid reports from OIG or from Casper and help determine what kind of opioid that person should be on or how to taper or whatever. The other thing that Casper does now is it's invaluable to me as a physician. I can get a reverse Casper. I can check with Casper to see if anybody's prescribing my prescriptions without my knowing if they got a hold of my prescription pad. So I can do a reverse Casper and see who's prescribing. I can get a report card. I can determine, Casper can tell me what my prescribing practices are compared to specialties in my area of the same specialty. Tell me how I'm doing. One of the most valuable things, though, is they have been able now, when you get a Casper, you get something called MEQ. That's morphine equivalents, or MED, morphine equivalents per day. Every guideline now says that morphine equivalents per day should not exceed 50 milligrams. Now, to determine that, you have to convert a opioid to
Doctor?
morphine equivalent. Yeah.
This is Chairman Bentley. We're running out of time. Could you sum up here in a minute or so?
The importance of that is that you have to convert everything to morphine. Morphine is 1. For instance, hydromorphone is 4 times 1. So if a physician doesn't know how to convert it, they can get that when they get a Casper. It's right on their MEQ. And you can tell if you're overprescribing, then you should, and get a report card. So I think it's invaluable to the practicing physician as well as the board. Thank you, sir.
Thank you, Doctor. We're going to start questions now. First one is from Senator Julie Adams electronically. So, Senator Adams, are you there? Senator Adams? Oh, we'll go back to her in a minute. Senator Berg?
Thank you again, and thank you, Chairman. Real quickly, do we have, and I'm not sure which of you I should be addressing this question to, but is there a way to proactively cultivate our Casper data to identify overprescribers in the state in a more timely manner? Are we doing that, and can we do that?
I can tell you as board, yes and yes. We can, and we were doing it. We would get reports from Casper for people who fell off opioid substances and they should be prescribing. And that sometimes came to the board.
And we have a way of interceding at that point
Yes.
before it gets to the FDA and all that stuff. We have a way as a state to jump in and say, your numbers are out of order. There's a problem here. What's going on? That's
what you commissioned. That's why you created the Kentucky Board of Medical Licensure. We would give that name to an investigator, one of our 6 investigators, and they would contact a Casper pharmaceutical representative and do an investigation.
And do we find that problem across the board with physicians, nurse practitioners, or are we seeing data that supports something over the other as far as safety and efficacy?
You've hit my pet peeve. The board, unfortunately, has no control over nurse practitioners. We have no control over what they do. They can prescribe what they want, and the board can't do anything about it. We control PAs and physicians, and that's it. Not we, the board, the Kentucky Board of Medical Licensure.
Yeah, and the Kentucky Board of Nursing controls the APRNs. And the model, I think, has changed to where we're seeing APRNs utilized a little more on the face-to-face interactions with patients. So you will see an increase in Senator Alvarado has been very instrumental in looking at this information as well. You will see an increase in APRNs over physicians. But I think as you look at how, the medicine has progressed, we're seeing a lot more face-to-face interactions with APRNs. It's becoming a more popular way to utilize them. So obviously they would be prescribing more because they are interacting more with the patient.
Okay, thank you.
Okay, Senator Meredith.
Thank you, Chairman Bentley. I guess I'm a little bit confused by the scope of this discussion. It appears to be that we're being sold on the importance of Casper, and I think all of us had that understanding, and we're very appreciative of the program and think it's a valuable tool for our practitioners. But I thought we were going to speak specifically about the status of the RFPs and where we are with that, and we just touched base with it. And again, RFP were closed May, I believe they told us, and here we are, October. Is there a go live date of December 31st? It's going to be impossible if we do see a change in this, but that's what I thought we were discussing today, and would like to have some more information about how this process is going. And again, if it's closed in May, we've had 5 months to review these RFPs, and where are we? Why haven't we made a decision? I think our legislative intent with the budget bill was to look at better ways, more efficient ways to possibly do this. We know that Casper needs to be updated, and there may be other alternatives out there that are less expensive, but I really don't understand why we're not having a focus on that portion of it rather than, again, the benefits of Casper, which we all recognize.
Yeah, Senator Meredith, to answer your question, it did close as far as any vendors coming into the process, but we can't discuss what happens after that until the process is closed per the guidelines. So unfortunately, we're not at liberty to kind of discuss where we're at within the process once it fully closed. It closed to vendors being able to apply for the RFP, but we can't discuss where we're at in the process.
Well, I hear that a lot, particularly when I'm in government contract review, that every time we have an RFP, we can't talk about anything. And I think that's intentionally used to lock out legislators from any discussion of this whatsoever. I don't see how giving us some kind of timetable is a violation of the RFP process. And it certainly appears that nobody's wanting to make a decision on this, particularly if we want this done by December 31st. And I think that's a crock to suggest that because RFP is out there, nobody can talk to us about this. I don't think that's correct. And I would challenge that.
Anything else?
Well, I got plenty, but I don't think they want to hear it.
Okay. I want to hear something I had to say too. Senator Adams?
Hey, thank you. Can you hear me now?
Yes, ma'am.
Okay, they muted me for some reason. Maybe someone didn't want me to ask a question, but here I am.
Okay.
And I'll be quick. Who actually does the inputting of data into Casper? Is it the pharmacist or is it the doctor?
The pharmacist does. I'm sorry.
So
the pharmacist.
When we write a prescription, we have to report it to Casper. Every physician does that. Any controlled substance has to be reported to Casper within 24 hours.
Okay, so you both have to report. Both the pharmacist and the doctor have to participate in what gets dispensed to the patient. Is that correct?
So it really, unless it's done electronically, Dr. Travis, not to interject, but unless it's done electronically, we would have no way of knowing. It's really more on the dispensing side that we are able to understand what's actually being dispensed. Because if someone gets a prescription, Dr. Travis writes a prescription on a pad and they never get it filled, then there is no real issue there. It's once it gets dispensed. So you'll see it more on the pharmacy side. But there are companies that are now doing the electronic prescribing and they interface. So it's a little bit of a combination.
When I use Casper, I write a prescription. I know exactly within 24 hours whether that patient's getting medicine from somebody else. What I'm writing, that's invaluable information that Casper gives me right away.
Okay, so when you write a prescription, if someone else fills it, then you are notified that that prescription has been dispensed to someone other than your patient within 24 hours?
I don't know the answer to that, Senator. I know that patient's not getting anything from me. And who they may give it to, I don't know. Casper has information on it. But I do know that patient is only getting medication from me and not someone else, not shopping, not doctors.
Okay. And I guess what I'm trying to get at is what kind of error rate do we have with Casper? I mean, whether it's the inputting of the correct prescription or the dispensing to the actual person that the prescription was written to. I'm trying to understand if it's a fail-safe system or if when they are when they're modernizing this, is this something that we need to take care of? Because what is our error rate?
Right. So there is an error rate, and it's very low. We are working on the modernization.
What does very low mean? What does very low mean?
It varies. It could be 1% of all. It could be 2%, 3%, somewhere in that range. It really does vary because they check it daily. So I'm sorry, I'm getting a lot of feedback. So yeah, it's hard for me to say like it is specifically this all the time because one day the traffic changes depending on the day, and so that can lead to higher error rates or lower error rates. But it typically runs between 1 to 3%, and that could be just a failure on. They need to re-query the information.
This is Chairman Bentley. Someone has their phone. It's not muted. We're getting a lot of interference. Back to you, Senator Adams.
Thank you, Mr. Chairman. So is that something that you all are working on to even, decrease that error rate and make sure that there's synergy between the doctor and the pharmacist, and that,
Yes,
what's getting is actually getting into the hands of the person that needs it?
Yes, we address any pharmacy errors, and we reach out to the pharmacists themselves or the pharmacy to have those corrected.
Thank you. Thank you, Mr. Chairman.
Sure. It's my turn now, I reckon. But Senator Meredith, you're going to get asked another question here in a minute. First of all, on FTEs, I looked at the national, what do they call it, the TTAC, PDMP policies. And Kentucky has 31 full-time employees, where the national average is 5. Can you explain that? I'm just doing the numbers.
Yeah. Yes. So most states, I think there's a handful of us now, that 5 total states that have their own systems. So the rest of the system are third-party systems. Yeah, it wouldn't show up that there are staff per se.
So did
that answer your question?
If they're only using 5, does that mean those states are more efficient than us?
They're paying a vendor to provide those services. So I don't know about efficiency in other states, but they're paying vendors to do what we're currently doing.
Yeah. So maybe 26 FTEs might pay for a vendor. So I'm just looking at
a lot of that is through grant money that we receive, so it's not out of general funds.
Okay. Now I have another.
And that grant money would go away. Sorry to interrupt. That grant money potentially would go away if it was a third-party vendor.
Okay. If you go to the Chapter 138 2 years ago, the governor signed a bill called HB 314, and the sponsor of that bill was me, and it has never been instituted. Can you explain that?
Which section are you referring to, Chairman?
I'm referring to a Casper bill that I sponsored, and Secretary Glisson helped me with it, where if a person goes to an emergency room and they have a high incidence or inclination for opioid misuse as a female, then that information would go to a pediatrician or OBGYN to help reduce a substance abuse baby. Yeah. We know those babies 2 years ago cost us $90,000 and probably $100,000 a year now. So if that was instituted and the OBGYN or pediatricians got that information and we could help produce babies, 10 of them that weren't on substance, then we'd save the state of Kentucky $1 million. So that's the reason I'm asking.
Sure. I have read the bill, and I did not read it as you have stated it.
I have it here with me. You want me to read it to you?
Yeah, that would be very helpful, sir.
It says to require certain hospitals to report positive toxicology screens to the Cabinet for Health and Family Services, permit federal prosecutors and agents to use Casper, permit practitioners or pharmacists to review Casper reports of birth mothers of potentially drug-exposed infants, remove a pilot program relating to real-time electronic monitoring, and make other technical corrections to amend KRS 218A.242 conform. Sponsors, Dan Bentley, Adia Wooshner, and Kim Moser.
Yeah, there are 2 provisions that I'm aware of that are in the bill. One is reviewing data on controlled substances that have been reported for the birth mother of an infant who is currently being treated by the practitioner for NAS or has symptoms that suggest perinatal drug exposure. And then the other provision that I'm aware of, and these are both functions that we feel fall under KHI, which is the Kentucky Health Information Exchange, because we're a dispensing program, not a health information program. And the second provision that I'm aware of is, in addition to the data required by subsection 5 of this section, a Kentucky licensed acute care hospital or critical access hospital shall report to the Cabinet all positive toxicology screens that are performed by the hospital's emergency department to evaluate the patient's suspected drug overdose. And I will say we are working with KHI. In fact, we've drafted a letter that we will send out on behalf of OIG to help institute that statute within KHI, but we don't have a mechanism within Casper that we would be able to do that.
Well, I'd like to have you report back to us when we have this meeting after the first year when we're in session, if you wouldn't mind.
Yes, and I think the birth mother language that you spoke of was in the original bill, but I don't know that it made it in the bill that actually passed.
Senator Meredith.
Thank you, Chairman. This is one of those administrative questions, and I'm sure you're fairly aware of 5042 section of the Federal Support Act, which requires these PDMPs to be qualified, in essence certified, and that was supposed to be effective as of October 1st. Are we certified?
Oh, Senator Meredith, I'll have to get back to you on that question.
No one knows. Is it we are or we aren't, or we're in the process, or? And the reason I'm asking is
I understand the question, Senator Meredith. I'll have to get back to you on the answer with that.
Thank you, Mr. Chair.
I have one more remote. Representative Steve Sheldon, are you there?
Yes, I am.
Proceed.
This would be, I guess, along the same questioning. Hello, Ms. Mather. I appreciate your presentation. And I've called several times and talked to you. You've always been just super informative, and I appreciate that. I really do. Couple quick questions. A minute ago, there was some question about, how many errors come through the Casper reporting system and how that works. But basically, all this, all the softwares that exist in pharmacy today have an integrating piece to it that at the end of the day, and it's different for each pharmacy, but we have to download that data and send it straight into Casper at least within 24 hours. It's pretty solid, rock solid. And of course, we tried to even go further than that required, because a minute ago, somebody had mentioned that, well, they wrote a prescription and we wouldn't even know if that had gotten filled unless they dispense it, which makes good sense. But there shouldn't be anybody writing prescriptions unless they've gotten a waiver, because all controlled prescriptions have to be electronic, right? Since January 1 this year. So my question is, have you seen a tremendous, and this may not be one that you could maybe answer, so I'll be fair about this. Have you seen a lot of waiver submissions from providers for not wanting or not able to comply to the electronic requirement that we passed in January?
We've seen about 1,000, and those are from, a lot of them are from smaller nonprofit entities that the software would kind of cripple them as far as performing day-to-day operations. So we have seen them, we review them, we have a team that reviews them. We are encouraging them and trying to figure out ways that they can comply. But we have seen about 1,000 waivers.
Okay, I appreciate that. I was just curious on how much of that kind of, I knew we obviously all expected some of that to happen, and I understand that, but sure. I know the technology is little to very inexpensive these days to be able to do that. So hopefully we'll get more and more of them come on board, but thank you so much.
Absolutely. Thank you. And we are encouraging them to look at avenues to be able to do that.
Thank you so much.
That concludes our questions. I had talked to Commissioner Lee, and I'm going to talk to her by phone because we're running out of time. It was a question I had directly for her on how they price the methadone. So thank you all for your presentations today. But before we adjourn, members, again, please note that remote access will be allowed to all meetings for the interim. Members will be provided Zoom link to access the meeting remotely, and the meeting materials will be made available online for downloading. Our next and last meeting for the interim session is scheduled for November the 16th. Members, please note this meeting date falls on a Tuesday rather than a Wednesday. So now, the last item is adjournment. Do I have a motion? So moved, and a second? We are adjourned.